Thank you very much, Leland, for the introduction, and to Kelsey Dumont, who was involved in inviting me to present to you today. I'm very thankful to have an opportunity to share with you about the experience that I had participating in the BC CSU Addiction Fellowship Program. So today I'll be talking about looking at expanding the circle, integrating pharmacists into addictions care. So before I jump in, just a little bit of further introduction for myself. This picture is top of mind in my household right now as we are very excited and looking forward to Halloween, wondering how we can top the costume of being a campfire and a s'more. So that's for me, I identify as a parent, spouse, also a cisgendered female, as well as a third-generation settler of European descent. So I want to acknowledge that I'm coming to this topic from a perspective associated with a lot of privilege, and I do try to be mindful of that when I'm approaching this work. Also wanted to acknowledge that I do have a background in hospital, as was mentioned in the introduction, so I'm not speaking to the role of pharmacists who are working in retail settings today. And then finally, also with gratitude to acknowledge that I did receive some financial support from the St. Paul's Hospital Foundation in order to actually complete the fellowship, which required traveling back and forth to BC frequently. And then also to pause and note here that I am presenting to you and I have the ability to work, live, and play on Treaty 6 territory, which is the cultural lands of the Dakota, Nakota, Cree, Saulteaux, and homeland of the Métis Nation. Pictured here, you see Wanuskewin, which I'm very thankful to be able to participate, go there often, ability to learn about history and culture of Indigenous peoples. And I do hope that we share a commitment to being stewards and good caretakers of this land. Also wanted to acknowledge that I trained in Vancouver, which is the traditional and also unceded territories. So not treaty territory, not ever given up. And these were of the Musqueam, Squamish, and Tsleil-Waututh nations. So certainly, I think working in the area of substance use and addictions, it becomes quite clear that by living here, we are continuing to live in a colonial state, and where systems, including our healthcare systems, are still in many ways designed to disadvantage Indigenous peoples, and that Indigenous people are disproportionately affected by substance use and substance use related harms. So I think by doing this work, we also need to commit to ongoing education, challenging the narratives around Canadian history and the context that we're in today, as well as all taking steps towards reconciliation. And just as a quick plug, on September 30th, a new documentary came out on CBC Gem, which was called The Good Canadian, and it really left an impact on me. So I would encourage, if you're interested in ongoing learning about our context today, to look that up. It's called The Good Canadian. So with the 45 minutes that I was allotted today, I'd like to share about my fellowship experience. And by the end of the presentation, my goal is that you'll be able to understand the fellowship program as a whole and explain how pharmacists can help contribute to addiction medicine teams. That would be the first half, and I can pause there to answer any questions that might come up in the chat. And then finally go into some of the research findings that came out of the qualitative research, which was a component of my fellowship as well. So what kinds of things led me to pursue doing an addictions medicine fellowship? And I think similar to many people, I have in personal life, whether it's family or friends, people who have been impacted by substance use as well as process-related addictions. And then working in acute care over the years, I started out in pediatrics and would commonly engage together with new parents and their infant, an infant who had sometimes been exposed to substances, and so supporting all of them through that time, initially through the withdrawal. And then going to St. Paul's Hospital, where people were often admitted in disadvantaged positions with conditions that were related to substance use, and in a vulnerable position being in a hospital because of our systems. And I have to say that I often felt quite ill-equipped to know how to be in these situations. I didn't know how to ask people about substance use. And certainly I also noted that there were areas within the system where stigma was persisting, and I didn't always know how to respond in that situation. And I just felt like overall we could do better with serving people in this hospital setting. Then I also went on to work in the chronic pain clinic at the University of Saskatchewan, helped to get that up and running starting in 2020, recognizing that chronic pain often overlaps with not only mental health conditions, but as a component of that, substance use as well. So all of these things, I think, led to my interest and ultimately my passion in pursuing the fellowship. So BCCSU, the British Columbia Centre on Substance Use, is a provincially networked organization that's based in Vancouver, BC, and they have a mandate to improve substance use through research, education, and then clinical guidance. You may be familiar with seeing some guidelines that have come out through the BCCSU. They're often well respected and trusted. Within the program, I work together with nurses, physicians, nurse practitioners, social workers. There was one other pharmacist beside myself. And then there's also a research stream where folks could focus on like the clinical aspects of research in addiction care. And this was a one-year program at about a half-time time commitment. In the beginning, we came together as a cohort for 2 weeks where we had what was called an academic block. So there was didactic learning on a variety of subjects, including drug policy history in Canada, substance use assessment, and then of course also management of a variety of use disorders. In addition to that, over the course of the year, we had an opportunity to learn in other areas. So we attended the Kwantlen First Nation, which is near Langley, BC, for a longhouse experience where we learned about Indigenous cultural safety. We had a few sessions on motivational interviewing training, all-day sessions on that, as well as academic half-days spread throughout the year for additional training. There were other academic activities we were involved in. So there were monthly journal clubs. We were responsible for each doing one of our own and then participating in the others. These were facilitated with leaders from the BCCSU as well. There were 2 conferences we could attend. The Canadian Society of Addiction Medicine happened to have a conference in Victoria that year, so I attended that one. And then the BCCSU also has a conference in spring in Vancouver called the BC Substance Use Conference. Then there were What's New presentations. So this was a once monthly, somebody from the fellowship does a presentation, and these are ongoing now. So I just wanted to let you know that you can sign up to attend these presentations done by social work, nursing, physicians, pharmacists about new emerging topics. So you can see most recently in October, they talked about the GLP receptor agonist for alcohol use disorder. There are also older presentations on there as well. So I would encourage you to check that out if you have any interest. The main focus throughout the course of the year was the clinical rotations. I was able to do these both out of province and some in province. So first, looking at out of province, I was with the addiction medicine consult teams that were in Vancouver, Victoria, and Surrey hospitals. And those were together with physician preceptors. So in that context, I was doing what the physician was doing, other than I'm not able to do diagnosis, that's outside of my scope, as well as no prescribing. But gathering the history and doing the assessment was part of what I was involved in there. And then there are pharmacists doing this work. So I spent some time at the Royal Alexandra Hospital in Edmonton, where I was with a pharmacist on the acute care addiction recovery program team. And at St. Paul's Hospital in Vancouver, there are pharmacists in a few different areas. So I was with the addiction medicine consult team, also spent some time with their opioid stewardship pharmacist. And then they have a program called the Road to Recovery, which is an inpatient detox service. Here in Saskatchewan, I was with the Rapid Access to Addiction Medicine team at St. Paul's Hospital. This was prior to the time when they diverted their resources to provide outpatient care. At this time, they were doing inpatient consults. So I was fortunate to be able to be part of that team for 2 weeks. I also traveled to La Ronge. I went in their health center and in their clinic, and was also able to travel to places nearby like Sucker River, which is about 30 minutes away, or Stanley Mission, which was a plane ride away, and learn about some of the challenges around accessing opioid agonist therapy for folks in more rural or remote areas. Then finally, at the Westside Community Clinic, I didn't realize how much I needed a primary care perspective in my life until I had this experience. But I think working in a hospital, we often see people at their worst, experiencing acute harms. And sometimes I think this can feel a bit discouraging, but going to the Westside Community Clinic seeing people doing well, seeing people with supports around them, seeing people feeling good on opioid agonist therapy and achieving the things that they wanted to in life. I think that was a very valuable experience for me. So what was I actually doing on rotation? As I mentioned, I was doing the consult as a physician on the addiction medicine consult team would do. So I would go in and have conversations about the substance use history, looking at assessment based on the components of the DSM-5, and then documenting all of this together along with an impression and a plan. This included assessing things like vaccination status, availability of naloxone kits, and then also looking for opportunities for education about harm reduction. I was involved in discussions, of course, as a pharmacist about pharmacotherapy, both for substance use disorder management as well as for withdrawal management. And all of this, trying to understand the individual's motivations and what their goals were, and trying to align treatment together with those goals. Also was involved in just checking in, seeing how things are going, making suggestions for medication adjustment based on a person's symptoms, and also answering questions from nursing staff about the treatment plan. And then finally, I did have an opportunity to build confidence in giving buprenorphine, the extended release administration, which some pharmacists, including myself, are licensed to give in Saskatchewan. And then a big component, building trust, building connections. And I think just to pause here to tell a couple of stories. The first being a gentleman who was described by nursing as being very agitated and very difficult to work together with. And when I went to speak with him, noting that he was quite defensive and feeling like he was not being understood in the hospital and not being treated appropriately. His primary concern was with his own pain management, noting that the nursing was concerned they weren't giving him medication because they were concerned about substance use. So it took time. It took sitting together with him. It took listening to his perspective and what he wanted to see happen in order to start to build a relationship. And by the end, feeling quite successful in having him trusting me, having that intensity in the discussion come down to be able to get to the point of talking about multimodal pain management and alongside the substance use. Another story of someone who stood out to me was somebody who was on her way out the door of her room when I walked up. And I think also quite agitated. I don't think she hid anything about the fact that she was going down to use substances, because she said, "You are not managing my withdrawal in hospital. I can't stay here." And so in that moment, she went, but then I went and followed up with her later, worked together on actually getting on top of that opioid withdrawal. And seeing that transition from the first time I met her until the last time I saw her, where at the end she was at the point where she was interested in treatment. She had lots of questions about what the options would be and ending up wanting to get on Sublocade in order to move forward. So these things that took time in building trust, but you could just see the transition over time. So before moving into the last pieces of this section, I wanted to pause to acknowledge with gratitude the physicians and nurse practitioner who were involved in supporting me here in Saskatchewan. I think I came out of left field with reaching out to them and wondering if I could spend some time with them learning about their practice, but I found them to be very welcoming, very supportive, and even helped me give my first Sublocade injection. So just to acknowledge these folks here with gratitude. So of course you go through the year and you do the training, and I think gaining the knowledge and actually being able to utilize it are two different things. And I would say one of the biggest challenges here is, it's hard to engage together with an addiction medicine consult team that doesn't exist. So while it's the standard of care in most places, I think every province in Canada has addictions medicine consult teams for inpatients. To my knowledge, nothing exists here in Saskatchewan yet, but I hope that that will be something that we see change, and that there'll be a role, consider being a role for a pharmacist to be part of that team. Also wanted to acknowledge that as a ward-based pharmacist, it takes time and consistency, as I had mentioned, in order to be able to gather a fulsome history and to start to build trust. And a lot of times pharmacists are putting out fires, or not necessarily in the same ward even from day to day. And so that can be a challenge as well. And then finally, not surprisingly, it's difficult to help people who use substances if you're working within a silo. So even if we could engage people on treatment in acute care, We also need to have transition support, wraparound care, and somebody to continue on the management plan when the patient leaves. And sometimes there's that disconnect between inpatients and outpatients. So what can pharmacists do? I don't want to paint a picture of all doom and gloom. There are many things pharmacists can still feasibly do. I think the first piece is around trauma-informed care, thinking about treating people with dignity and respect, and finding ways that we can offer folks choice and control in situations where often control has been taken away from them. We can also challenge stigma. So we might hear disrespectful language. Perhaps the terms drug seeker or frequent flyer are still thrown around in acute care settings, and we can help to bring compassion and understanding to how some of those terms might be hurtful or unhelpful. We can ask about active substance use. So when we're talking about other medications, to build this into the conversation, at least looking at like how much, how often, what route, and when did you last use? And maybe not going through the whole list of every substance under the sun, but even just focusing on nicotine, alcohol, and opioids. Finally, on the left-hand side, knowing the resources and the context and looking to connect people together with resources. So if you know that there are addictions medicine providers and you can help connect people when they want to receive treatments, that can be a very valuable role. We can assist with withdrawal management, but not just opioids, remembering nicotine, how uncomfortable it can be to be going through nicotine withdrawal. And if we can help even just taking that edge off, that's a valuable piece. Pain management is another one, helping people to avoid their opioid deficit while they come into hospital and exploring the multimodal strategies. Doing proactive discharge medication planning. So even asking somebody what their preferred pharmacy would be. Then if they leave before is medically advised, maybe we can help coordinate a prescription to that pharmacy because we had that conversation about where it could go, as well as thinking proactively about cost coverage barriers which may arise. And then the last one within the pharmacist's wheelhouse, thinking about drug interactions. So phenobarbital is becoming used more commonly, knowing that it can decrease buprenorphine or methadone concentrations due to enzyme induction over time. So being mindful of that. Thinking about when folks are taking naltrexone and how that might limit severe acute pain management with opioids. And then also thinking about concurrent medications that might increase or decrease seizure threshold or increase QT prolongation risk. These are all things that can easily be on a pharmacist's radar. So lots of places where pharmacists can help contribute to patient care. I am just going to pause here, see if there are any questions about anything I've described so far before I move ahead into the description of the resources or the research. If not, there's time for questions at the end as well, so we can come back.
Nothing in the chat, no hands up yet. So
thank you. Great. Okay, so part of the fellowship was also to do a research project. So this was published in the Canadian Journal of Hospital Pharmacy earlier this year in May. And the link is available on the slide here, but you can also Google it. I think it's available for free. It's called The Role of Pharmacists in Addiction Medicine in Canada's Publicly Funded Healthcare Systems, a Qualitative Study. And these are some of the folks that I would like to thank for working together with me on the research. Dr. Caitlin Halpappy is based out of the University of Saskatchewan in the College of Pharmacy and Nutrition, and she was instrumental from start to finish in helping to work on this project. So I'd like to identify her. And then Dr. Mona Kwong was the director for the Addictions Pharmacy Fellowship. So I'm thankful to her for making this all happen. And then to acknowledge that CRISM, which is the Canadian Research Initiative in Substance Use Matters, they have a Prairie node. They provided us with some funding in order to pursue external data analysis for the project. So in this case, the problem we identified was that there are a large number of Canadians who were requiring healthcare each day as a result of substance-related harms. And while addiction medicine consult teams are becoming increasingly common in North America, little is ultimately known about the role that pharmacists can play on these teams. So what we did is we started by conducting a literature review. And we did find a few articles. They were all based on US data, and these described publicly funded pharmacists who were involved in very specific clinical roles or administrative tasks, but they had little to no outcome data associated with their interventions. So we did find a scoping review, which was published in 2022 by Irvin and Walkerly, and they were looking at interventions by pharmacists, and they noted that it is reasonable to hypothesize that the involvement of acute care pharmacists in opioid use disorder harm reduction interventions has the potential to improve overall outcomes in the inpatient or emergency department settings. But in order for this hypothesis to be testable, they say there needs to be greater delineation in the literature of the types of roles acute care pharmacists can play. So as a result, we sought to answer the research question, what roles are pharmacists who work in the area of substance use disorder management holding in Canada's publicly funded healthcare systems? So again, acknowledging here that I think folks are often quite a bit more familiar with the role that pharmacists working in retail settings have, such as in dispensing opioid agonist therapy in the community setting. In this case, by publicly funded, we mean pharmacists who are working in acute care, emergency department settings, or publicly funded ambulatory, primary care, detox, or residential facilities. So we had 3 objectives. First of all, we had to find these people. I didn't even know how many folks we would be able to find within Canada. But we did seek to find pharmacists with a specialized focus on supporting people who use substances who are working in these settings. And then we wanted to summarize the activities that they were involved in, along with the facilitators and the barriers to the services that they were providing. And then finally, to look at the value that their unique training was adding to the teams. So as mentioned, this was a qualitative study, and we sought to conduct up to 15 virtual semi-structured interviews, and we were using a pre-established interview guide. We obtained ethics approval before beginning, and then the coding and analysis was done by the Canadian Hub for Applied and Social Research, also called CHASER, based out of the University of Saskatchewan. They're a research support and consulting service. So we did recruitment by sending out emails in as many directions as we could possibly think of, as broadly across Canada as we could. What we were looking for is pharmacists who were practicing in Canada, who spoke English, and who were involved in direct patient care in the area of addiction medicine. We did decide to exclude people working in opioid stewardship roles, recognizing that this is a pretty broad term that can mean different things in different areas. But we wanted to exclude folks who would be working in assisting with pain management only, although of course we recognize the overlap with substance use disorders, and also excluding those who were involved in activities that were aimed exclusively at preventing opioid use disorder with a focus on supply reduction strategies. We also excluded those working in community or retail settings as pharmacists and those working in administrative roles only, so meaning they had no direct involvement in patient care activities. Participation was voluntary and participants were not compensated for their involvement, but despite this, pharmacists were very keen to share their stories and their experiences with us. We reached our max enrollment within the first 2 weeks of sending out a call for participants. As you can see, 27 people contacted us about enrollment, and then 15 people completed the interview. I conducted the interview, all of the interviews in late January and early February of 2024, and these lasted about 60 minutes, and the conversations were recorded verbatim. And then all of those who participated in the interview either provided written or verbal consent at the beginning, and then they also reviewed their own transcripts to verify their accuracy prior to finalizing them. So you can see our general demographics here. I would like to highlight that pharmacists were working in a diverse practice settings and roles. So just under half of them were working exclusively in acute care. And also just over half worked together with a prescriber who had some specialized training or experience in addictions management. So the remainders work together with pharmacists or prescribers who were not specialized in addictions medicine, so might have been psychiatrists or family physicians. Most of our participants were located in urban sites, and over half of them were from BC. So 8 participants in BC, but we did have representation from most of the provinces across the country, including one from Saskatchewan. When discussing their training, participants identified a variety of educational pathways, including post-secondary educational degrees, diplomas, and formal certificates or credentials. After completing a formal pharmacy undergraduate degree, 2/3 of the participants also completed a PGY1 residency, and 1 person had also completed a formal addictions medicine program. There were numerous self-directed learning courses that were also mentioned, as seen on the right-hand side of the slide here. And when we asked what type of training would be required for those entering the role, many mentioned that clinical training, such as a residency, should be required. There were numerous different activities that pharmacists were describing that they're involved in. Notably, pharmacists were involved in education for patients and also for providers. They were involved in making medication recommendations. So an example of this being as an opioid agonist therapy transition from one to another. Also helping prescribers with managing the prescriptions, the logistics, such as for opioid agonist therapy, and utilizing their scope to prescribe independently when appropriate, such as for things like contraception and vaccination. A key component to that, almost I think everyone described, was communicating or liaising together between hospital and community providers at the transitions of care around management plans. And then finally, they described strengthening the therapeutic alliance. They were just another healthcare provider who were able to connect together with the person, check in, see how they're doing, and then ultimately helping to build trust in the system as well. So this is a summary of our interview objectives as well as some of the themes with some sample quotes from the participants here. Participants were surprised by the amount of stigma or stereotypes that they encountered in their work, and also the emotional connection that they ended up establishing together with their patients or clients. They described barriers associated with their scope of practice or with time limitations. And they noted that elements that strengthened their ability to provide good care included being able to establish rapport with clients, as well as having a collaborative team to work together with. In terms of their value add, many pharmacists discussed their medication-specific knowledge, particularly in their ability to quickly triage and address drug therapy issues, such as how other medications might, influence treatment as being an asset. So this study was important because, to our knowledge, it's the first study that looks at publicly funded Canadian pharmacists in these roles. And just a comment from one of the participants, a quote here, who indicated, "We're all up against a broken system." So in many ways, needing it to be kind of an all hands on deck situation where people who have ability to help support individuals who are using substances, that they do so. Recognizing that pharmacists have a broad knowledge base, such as medications that can change your seizure threshold or prolong QTs, or with drug interactions, can help with transition to community and also help with the cost coverage pieces. Pharmacists are very adaptable in terms of their skill set, so they can help fill the gaps in the individual circumstance or the community that they're working within. And then in conclusion, recognizing that people really are carrying a large burden of substance-related harms, and there is a role for pharmacists to help increase the capacity of the system and support patient wellness. Pharmacists are able to support medication management in the context of an ever-changing, often gray area where evidence-based medicine is not always possible, can't necessarily keep up, and that person-centered care is foundational. And then finally, system-level support is needed, along with more data on outcomes associated with implementing pharmacists as members of this team. So these are the references that we use for the research. And we have about 15 minutes left for any dialogue, questions, discussion that anyone would like to bring forward. Thank you very much for your attention, and again for the opportunity to be able to come and tell you a little bit about how I spent my year in traveling back and forth to BC.
Thank you so much, Amy. Very enlightening, and thank you for sharing your experience. I'm going to turn the recording off, and then we'll enter the Q&A.